the race for the long-delayed male birth control pill. Now, some of you might remember the first session, and I talked a little bit about what I do. I do obstetrical anesthesia. And I've said that there are a few people that like me better than a woman in labor. If men had babies, we would have no need for this study. We should have talked to them about it, honestly. I'm reminded nearly weekly by my wife how much a wimp men are. And we wouldn't put up with the 9 months of pregnancy and the throwing up and the deliveries. So, anyway, it's my pleasure to introduce the first two speakers for this session. Dr. Bill Bremner is our first. He's a local boy, local guy, made good. He grew up by Linden, by the border. He currently, and I always forget that. You know that I do. He serves as the the chair of the Department of Internal Medicine and holds the Robert G. Petersdorf Chair. His interests are metabolism, endocrinology, nutrition. He's the founder of the UW Center for Research on Reproduction and Contraception. His current interests are, how you like this, mechanisms for central nervous system control of pituitary gonadotropin secretion and effects on gonadotropins and gonadal function. What is that all about? Even in anesthesia. I went into anesthesia so I could stay from here up, and that's where all of this happens. And he, I hope, will tell us a little bit about what that means when he gets started here. Bill received his MD degree from the University of Washington in 1940. Not for, not that he's that old, but anyway, yeah. And then did a NIH pre-doctoral fellowship in psychiatry here. He has residency in internal medicine and a fellowship in endocrine at the internship at Vanderbilt first. So he had to always go away from the U and then come back, and go away from the U and come back. Internship at Vanderbilt in Nashville, and then a residency in internal medicine and a fellowship in endocrinology back here, and then really went away from the university to Australia to do a PhD in reproductive endocrinology. So Bill and I are what I call real doctors. We have PhDs, and then we are also barbers, that we became MDs at the same time. Slide 3 here. He serves as a consultant to NIH and the WHO and the U.S. Olympic Committee. He's an active skier. Makes a lot of sense. Strap 2 6-foot boards 2 inches wide on your feet and go down the hill at 60 miles an hour. And as one becomes more osteoporotic, one might want to worry about that just a little bit, Bill. He's joined in Seattle by his wife, Jane, 3 children, Jenny, Andrew, and Tim, all of who had sense not to go into medicine, and they're in all forms of education here, and 3 grandchildren. Our second speaker is John Amory. He's the associate professor of general internal medicine and attends on the general internal medicine inpatient service at the university. His interests are male contraceptives, androgens and aging, testosterone replacement, Klinefelters, which is an interesting problem, and I'm sure he won't talk about that tonight, and male infertility. He received his MD degree from UCSF and his residency at UCSF, University of California, San Francisco. I love the place. I spent 2 years there as a fellow. Also, it's a great place to visit. Not a city I'd want to live in, but a great place to visit. He's won numerous awards, the Helen and Phil Fialco Scholarship Award and the Paul Beeson Excellence in Teaching, all names, if you're in internal medicine, that are high-flying names. And he's won awards named after all of those folks. He enjoys cycling. He did the ride around Mount Rainier. It's a one-day, 156-mile trek. I would have taken an aspirin and laid down, but he rode around. And I also don't look good in spandex. I should not wear spandex. He's interested in history, sports, what can I say, sports cycling, sports coaching, soccer, basketball. He's joined in town by his wife, Josie, the children, William, 8, and Thomas, 6. So our first speaker is Bill Bremner, and he's going to speak on the need for additional contraceptives, and then John will speak after that on the research on new reversible male methods. Bill?
Well, thank you very much, Brian, and thanks to you all for coming tonight and working with us on this interesting topic. These are the three sections of tonight's program. I'm going to be talking about the need for additional contraceptives in general, particularly related to men. John is going to talk on research largely that's been done here at the University of Washington, and then Brad is going to add additional comments, including talking with some of the men who participated in these studies. So what about the need for additional safe, effective, reversible, affordable male contraceptives? Lots of adjectives. There is a need, we believe, worldwide for a wider choice for couples for contraception choices. And some of the reasons for this include what's on the slide, which are that 1/4 of pregnancies worldwide are unwanted. This is a fairly stable number across a variety of cultures, interestingly. And that there are high maternal death rates, particularly in developing countries, associated either with normal deliveries or with unsafe abortions. And I'll go into that a bit more detail in a few minutes. So the main first topic being the need for additional choices for couples for contraceptive technologies. Secondly, we're experiencing a dramatic expansion of the human population with resultant effects on the environment, resource depletion, food availability, cost. Food costs, particularly in developing countries, have dramatically increased in recent months, and potential political instability. So we can start with a little pre-talk quiz here, and let you take a guess as to what you think the percentage of all contraception in the United States is that's achieved with male-directed methods. These are in married couples. And I'll give you choices of 0, 5%, 10%, or 30%. Unfortunately, we don't have the little clickers that you can do the audience participation in, but anybody want to take some guesses? I hear 10, 5, 0. It's 30%. So that, of course, is usually surprising, and I'll touch more on that in a little bit. Just to jump ahead, it's about 15% condoms and 15% vasectomies. So is there a need for additional contraceptives? This now getting back to the need for additional choices. There are figures that the World Health Organization and the World Bank put together about 15 years ago on that always makes me and sometimes the audience a little nervous as to how they know how many acts of intercourse are going on each day. I feel like you might see somebody from the World Bank coming around your place, but they, at any rate, estimated to be 100 million acts of sexual intercourse per day worldwide. Approximately 100 million women conceive per day. About half of those are unplanned, and about 1/4 of them are unwanted, and seriously unwanted, not just an inconvenience. And about 150,000 a day are terminated by induced abortion worldwide, and about 1/3 of those occur in settings of poor health care and unsafe conditions for this procedure, resulting in approximately 1,600 deaths of otherwise normal young women per day worldwide. Turning then to the population, we had a reasonably stable population for thousands of years until the beginning of the last century, when the increments, which are shown in the histogram portion of this, started dramatically increasing, leading to increased size of the population, as shown in the solid red line. And the increments are on the left-hand axis in millions, and the total population is in the right-hand axis in billions. And we have recently, as you probably have read, passed the 7 billion human being on Earth level due to these dramatic increases in the increment in each period of time. So what are we going to do going forward? There are a variety of projections out there for what will happen over the next 50 years or so, which is about as far as anybody's been willing to hazard a guess. These are a series of figures from the United Nations population projections, with the top line on this graph being what would happen if we continued at our present fertility rate, and the lower lines being other rates of population increase. And from a low level to the high level projections, with the high being in the blue and the low in the purple. The one that you frequently see in the news is the medium range projection, the green line in the middle. And I just want to underscore that that's dramatically different from what will happen if we continue at our present fertility rate, which would get us to about 12 billion people by 40 years from now. So another way of looking at what might happen with the human population is the rate of increase, or the absolute level of the human population that will occur as a function of how many children each woman in the reproductive age group bears. And there are dramatic changes in the total population as a result of relatively small changes in the fertility rate, and that's shown on this graph. That a replacement rate is somewhere around 2.05 to 2.1 children per woman to replace herself and a male, and allow for some loss prior to entering the reproductive age. At only 2.5 children per woman, though, presuming current death rates, the population continues to increase dramatically, and you can see how that would affect the axis on the left-hand side in billions. Keep these lines in mind when I put up the next graph, however, because it shows what would have happened if we had continued at the 1990 fertility rate, which is the red line. The three that I showed you on the previous slide are all scrunched into the bottom of this graph. So the changes that we've made already in fertility rates worldwide have had a dramatic impact on the projections for total population growth. But there's the world rate for reproduction of children per woman is estimated to be somewhere still around 3 at least, with some countries still being as high as 6 or 8. So this is not a problem that's been fixed. So again, if we go back to the United Nations mid-range projections, which I would argue are optimistic, still there will be a 40% increase in the world population in the next 40 years to about 9 billion. This will occur predominantly in the developing world, which will increase from about 5 to about 7.8 billion in that 40-year period of time. And the developed world will be reasonably stable, with some countries actually losing population, particularly in Europe, perhaps in Japan. The United States is unusual among developed countries in that the population will continue to increase quite dramatically, and that's in large part because of immigration. We're now the world's leader in terms of immigrant populations, with about 1.1 or 1.2 million per year coming into this country. The total population is projected in the United States to reach 400 million over the next 40 years. Mexico's population, about 100 million, is expected to double over that period of time. We see a lot in the literature about environmental pollution, global warming, and so on, and it's uncommon to have that related to the numbers of humans in the population, surprisingly. There's, of course, an argument going on around, is there really climate change occurring, and if so, why is it? Even the previous government administration, which of course was a relatively conservative government, concluded that the atmosphere is indeed growing warmer, and there's clear evidence of human influences on the climate system. In the scientific literature, there's repeated warnings about future food insecurity with unprecedented seasonal heat, this being an excerpt from a recent science paper on ignoring climate projections at this stage will only result in the worst form of triage. World water supply, about a third of the world's population have no access to clean drinking water, and that's projected to worsen. About 3 billion people have no toilets, and that number has increased. And our infectious disease colleagues remind us when you have a medieval level of sanitation, you have a medieval level of disease. This is an old slide from a paper about 15 years ago in Science, estimating the world's carrying capacity. That is, how many people can the Earth contain or support. Estimates have ranged between about 7 and about 13 billion people, going all the way back to the 16 or 1700s. People have made estimates in that range. And the population at that time, only 15 years ago, was 6 billion people. As you know, we're now at 7 billion. We've added 1 billion people in the last 15 years. At that time, there was the warning that the human population is entering a zone where limits on the human carrying capacity have been anticipated and may be encountered. Some of you may have read some of the Jared Diamond books. This is an excerpt from his book, Collapse, or How Societies Choose to Fail or Succeed. And two of the major factors he pointed to in a variety of societies' collapse were population growth and the increased per capita impact of the numbers of humans, resulting in starvation, war, disease, and collapse. This was an interesting excerpt from a Thomas Friedman book on Hot, Flat, and Crowded, which was a bestseller, that population growth has come on so big, so fast, that General Michael Hayden, the director of the CIA, stated that his analysts believe the most worrying trend in the world is not terrorism, but demographics, and quotes him that population growth will likely fuel instability and extremism. Quotes countries including Afghanistan, Liberia, Niger, Congo. Populations expected to triple by the mid-century, and others in Africa and the Middle East that were more than double, and as a result have a huge concentration of young people. And if their basic freedoms and needs such as food, housing, education, and so on are not met, they become easily attracted to violence, civil unrest, and extremism. Remember, this is the general who's head of the Central Intelligence Agency. There have been lots of literature on the climate change and the environment. Again, it's relatively uncommon to have this linked to the numbers of people that underlie it, but certainly the numbers of people and the amount of resource consumption and environmental pollution that's produced are critical to this concept. More recently, the National Geographic has just had a cover article on the 7 billion population, and is going to have a series of articles on population growth, which may be of interest to you. Is there any relationship between the rate of contraceptive use and human fertility, really, if you look across societies? This is a graph showing a large number of sections of the world in comparing the contraceptive use rate with the total fertility rate, and demonstrating that the higher rates of contraceptive use are associated with lower rates of fertility. There are, as I touched on, existing, of course, male methods that are used more commonly than most of us realize. So again, the condom is used about 15% of couples, and vasectomy another 15%. Both have many advantages, and vasectomy is an excellent permanent technique. It can't be regarded as usually reversible. The condoms have much to recommend them, a moderate efficacy rate in terms of preventing fertility, an important role in terms of preventing infectious disease transmission. They do have, though, problems of decreased compliance and efficacy because of the requirement of course, being related to every episode of coitus. Again, this is a table of use rates, and male sterilization being 14% in these data, and the condom being 17%. This is data from quite a while ago, but these numbers have held up And I think John may come back to this issue as well. What about acceptability? Would men use the technique if it were available? We've already talked about a third of men use the existing methods despite their defects. And men surveyed about the potential use of a hormonal reversible contraceptive, get about 50 to 80% of men surveyed in a variety of cultures and religions have reported that they would use such a method. A common question I get when I give talks such as this is, yes, but would the women trust them to use the method? And in the survey, again in the literature of these same areas, 98% of women in stable relationships said they would trust their husband to use the method. How accepted and used over longer periods of time are existing female methods. There are a variety of reported continuance rates in the literature. This means how many people would use it for more than a year of oral contraceptives ranging from 25 to 80% continuation, IUDs 40 to 90, and injectables 22 to 63. Of course, we're all familiar with our families, our friends, et cetera, women having difficulties with any one of these existing methods and determining that that wasn't for them and wanting to switch. And certainly that's the origin of many of the male volunteers we get in our studies, is couples in which that's true. So there does seem to be a substantial need for new techniques. So how have we done at introducing new male techniques? This is the most recent introduction of a new male technique that's reversible, which was the condom in the 17th century. It's gone through vulcanization of rubber, there's latex, there have been improvements, but still not a new method really on the market for males for quite a while. So at that point, I'm going to stop, turn it over to John Amory, my colleague, who's going to carry on talking about work that we have undertaken and other groups around the world.
Well, thank you so much to the organizers for inviting me here to talk today with my wonderful colleagues. Bill, I think, gave you a very nice overview of why we need a male contraceptive, and now I'm going to focus primarily on, is it possible? And I'm going to cover very quickly some research that's been done here at the University of Washington over about the last 30 years attempting to develop a practical, safe, and effective form of reversible male contraception for men. And almost all of this work focuses on using hormones. And if you think about it, this is very analogous to the situation in females where hormones such as estrogen and progesterone are the basis for reversible female contraceptives. We're using a very similar approach in our approach to developing a male contraceptive, trying to use hormones that, after all, are a natural product that all men are exposed to naturally suppress and reversibly suppress in this case, the ability of men to make sperm. And I'll show you how that's possible. So Bill showed this data, and I just want to reiterate this. I think this is a very important thing. And when I tell people what I do at cocktail parties all the time, they say, oh, men would never use a male contraceptive. I beg to differ. I think based on this data, very similar to what Bill showed, you can easily make the case that men are using contraception, and not just using it, some men are actually having surgery on their scrotum because they want to contracept and they really don't have viable options. So the men who do our studies, we usually get very eager volunteers for this study, and we usually can recruit for those studies because there is a need out there for couples to have more forms of contraception. So I'll tell you a little bit about, we're not the only group in the world working on this. There's about a dozen groups around the world that are working on trying to develop male contraceptives, and almost all of them in the clinical trials that they've done have focused on this hormonal approach because it's easy. There's a precedent for it in the female contraceptive arena, and it works fairly well, but not quite 100%. And I'll show you some data on that in a minute. However, you take all the studies that have been all around the world enrolling men in clinical trials of hormonal contraception, and there's about 3,000 worldwide, you can show that it's always reversible. There haven't really been any cases where a man has enrolled in a contraceptive trial, taken testosterone and other hormones to suppress the sperm production, that man has not fully recovered sperm production. So that's very good news for our volunteers and very good news for that approach to method development. One drawback to using the hormonal approach to contraceptive development is it doesn't work right away. So this method of contraception is not for the casual user. The biologic basis for this is it takes about 70 days for the sperm to go from its stem cell to a mature spermatozoa in the ejaculate. Because of that, when we give hormones, we're actually shutting off sperm production. The existing sperm have to work their way through the system. So as you'll see when I show you the graphs, the sperm counts in our volunteers don't fall immediately. They take about 2 to 3 months to go to 0. Similarly, when a man stops the hormones, it takes about 2 or 3 months for the sperm counts to recover to normal. So this is not a method for the casual user. This is not an as-needed method. This is a method for a man who wants consistent and reliable contraception for a certain period of time before either fathering a pregnancy or moving on to something else. When you do survey men, and drug companies have done this because drug companies are interested in producing products with markets that they can sell to, you can easily say that more than half of men, regardless of their cultural background, are interested in this approach to contraception. And as Bill mentioned, women would trust men to use such a contraceptive, although just to elaborate on that, when he gave you that 98% figure, that was women trusting their partner. Men in general scored a little less well. So that's a positive number, but it's not true of all men, just the man that the woman happens to have as a partner at that point in time. So how do we do this? Well, it turns out that if you give a man testosterone, the hormone that he makes, and you give it naturally, and if you give it to him in a dose a little bit higher than what he would normally make, you will actually turn off his sperm production. How does this work? And I'll show you a diagram in a minute. But it works basically by suppressing the signals from the brain to the testis to make testosterone. The body has these very elegant feedback mechanisms that can be disturbed in this way. When you give testosterone, it'll turn off the body's signals to produce testosterone, and in doing so, will turn off the signals to produce sperm. Testosterone alone works, actually induces a sperm count of 0, something we call azoospermia, in about 2/3 of men. But it doesn't do it in all men. The other remaining men will suppress their sperm counts, but not to levels that we think are compatible with effective contraception. So what we do, and what's been done, very similar to what's done in the female contraceptive world, is we combine hormones. Most female pills that you're aware of use both estrogen and progesterone. In the male arena, we use testosterone and progesterone. The analogous hormones that are used in women also have a suppressive effect on male reproduction. So let me just walk you through this diagram. Starting out here, what you're seeing is this is what we call the hypothalamic pituitary testicular axis. So your reproductive function is under elegant control of your brain. And specifically, there's an area of your brain called the hypothalamus, which just means it's below the thalamus. And this secretes a hormone called GnRH, which stands for gonadotropin-releasing hormone. Gonadotropins are just what they sound like. They are trophic or stimulatory for the gonads. These gonadotropins, the two that you see here, FSH, which stands for follicle-stimulating hormone, and LH, for luteinizing hormone, are the exact same hormones that are present in the female. Women have FSH and LH. In the female, they act on ovaries to induce ovulation. In the male, they act on the testes down here to stimulate sperm production and testosterone production. These hormones are secreted by the pituitary gland in the middle there under the influence of gonadotropin-releasing hormone. By the way, there are 2 cell types in the testes. The Leydig cells are the cells that are important for the synthesis and secretion of testosterone, which is the most important male sex hormone, and the Sertoli cells, which you can really think of as nurse cells, which nurse the developing sperm. And you need both of these cell types to produce sperm. So what happens in the setting of, this is the normal hormonal control of sperm production. And by the way, I'll tell you that this axis is quiescent until puberty. So little boy, I have 2 sons, as I think you saw in the picture, and people are always joking with me and say, oh, because they're wrestling and fighting with each other, and they say, oh, it's the testosterone. Not so. Because in prepubescent boys, before the age of puberty, there's very little testosterone present. So perhaps it's poor parenting, but you can't blame the testosterone for the behavior of my 2 little boys. So this axis is quiescent until puberty, and at puberty, for reasons we don't fully understand, the hypothalamus starts secreting GnRH, which acts on the pituitary, which then starts to secrete FSH and LH. In the female, you would get menses, you would get the menarche, and in the male, you get the initiation of sperm. So what happens in the setting of a male contraceptive? Oh, and one critical point that I wanted to make is the testosterone that's produced by the Leydig cells, it has all of the functions that we think about, the things that transform a boy from being a boy to being a man. It increases height, it increases muscle mass, bone density, it deepens the voice, it starts the facial hair growing, and all of these important things. One of the very important things it does is it goes back into the testis at very high concentrations, and Dr. Anawalt's going to talk about that later. And these very high concentrations of testosterone within the testis, or intratesticular testosterone, turn out to be necessary for sperm production. It also, and this is crucial for the development of a male contraception, it also exerts what we call negative feedback at the level of the pituitary and the hypothalamus. In other words, it controls its own production in a very elegant feedback loop. The brain, however, doesn't know where the testosterone is coming from. When the brain sees testosterone, it assumes it's coming from the testis. So that if you give a man external or exogenous testosterone, it will exhibit that same negative feedback on the brain. What does that negative feedback do? Well, it lowers the levels of FSH and LH, essentially putting the testis back into its prepubertal state where it wasn't making sperm. Absent signaling from FSH and LH, the testis no longer makes sperm. The individual doesn't notice it. He doesn't notice an absence of testosterone because it's being supplied externally. But the testis knows that the testosterone isn't there, and sperm production will decrease or cease entirely. Probably because we're dramatically decreasing these intratesticular concentrations of testosterone. Does this graph make sense? Okay. And then, as I mentioned, the other thing we're doing, the progesterone actually also exerts a negative feedback. So if testosterone alone is insufficient at suppressing FSH and LH, the combination of testosterone and progesterone is actually more suppressive, and I'll show you some data from that combination. And then you can wipe out sperm production. The nice thing about this is if you understand this axis, you understand why this is reversible. When we take the exogenous testosterone and progesterone away, the axis wakes back up, just as it would at puberty. The hypothalamus starts secreting GnRH, the pituitary starts secreting FSH and LH. Responding to those signals, the testis then starts to make testosterone and sperm on its own. And an individual just transitions back to the state he was prior to the application of the external hormones. So I'll show you some data from one really seminal study in this field, and this was conducted by the World, there's no pun intended, the World Health Organization did a study. This is back in the 80s, using testosterone alone as a contraceptive. And they enrolled 271 couples, so a man and a woman, at 10 centers worldwide. And the men were just given weekly injections of testosterone. The female partner then had to agree to not use any form of contraception for her, so we could see, does this method of contraception, that is weekly testosterone injections, is it efficacious at preventing pregnancy? 2/3 of the men suppressed to a 0 sperm count, and those men were allowed to enter into this efficacy phase. And of those 150 couples who used this method for roughly a year, there was only 1 pregnancy. So that's a very high efficacy rate. So what this study demonstrated is that if a man uses hormones and achieves a sperm count of 0, that the couple can fairly reliably rely on that as a method of contraception. Now you may be wondering, how did that 1 pregnancy occur? The man had a sperm count of 0. Well, that's what the investigators wondered as well. So have you heard the expression, mother's babies, father's maybes? So one of the challenges to developing a male contraceptive is that paternity is not always clear, and I will leave it at that. So investigators went on and asked the question, well, if we can get a man to sperm count to 0, that's pretty good, right? If a man has no sperm, conception is pretty much not likely to happen. But what about if we got the sperm count pretty low? And so what you're looking at here is a graph from a follow-up study, also conducted by the World Health Organization, in which 399 men in 15 countries were enrolled on the same regimen of weekly testosterone. 391 of those men, so roughly 98%, suppressed their sperm count to less than 5 million sperm per milliliter of ejaculate. That still sounds like a lot, but when you think about a normal man having anywhere between 20 and 200 million sperm per milliliter of ejaculate, getting down to less than 5 is actually pretty good. And then they asked the question, what are the pregnancy rates associated with the various sperm counts? And so what you're seeing here is on the y-axis, this is the pregnancy rate per 100 person years, roughly a % pregnancy risk. And on the x-axis, you can see the men were subdivided into categories depending upon their sperm count. And the leftmost side of the x-axis, you can see where it says azoospermia. Those are men who had a sperm count of 0, and their pregnancy rate, logically, was 0. So that's good. Again, confirming the results from the earlier study that a sperm count of 0 is associated with a very low risk of unintended pregnancy. A sperm count of 1 million, which is the next column, is associated with a pregnancy risk of less than 1%. So that's pretty good. That's very analogous to the efficacy rate of the female contraceptive. And you can see as the categories go up, 2 million, 3 million, 4 million, and 5 million, the pregnancy rate goes up. But you'll notice even at 5 million, the rate of unintended pregnancy is only roughly 3%. So this is pretty good. And it means that if you can get the sperm counts low enough, you may have an acceptable efficacy rate. Investigators in the field have looked at this data and said, you know what? I think if we could get 100% of men to less than 1 million sperm per milliliter of ejaculate, that might be pretty viable as a contraceptive. You can decide whether you agree or not. But certainly it's clear that no method of contraception is associated with a very high failure rate. So a failure rate of 1% may or may not be acceptable depending on the individual. So what do people always ask me, they say, testosterone, doesn't that make you crazy? Aren't you going to like go out and punch cars or something? So it's important to talk about the side effects. And I want to preface this discussion with the idea that all men are exposed to testosterone for most of their lives. So testosterone is not something you can be allergic to, and it's not something that's going to make men into monsters. Men have it. And what we're doing here with this approach to contraceptive development is giving them just a tiny bit more than their bodies would normally make. But that tiny bit is associated with some side effects, so it's worth detailing those. First of all, it's clear, and from studies that we've done of body composition and so forth in men on these contraceptive studies, they do have a slight increase in muscle mass and weight, roughly in the 5 to 10 pound range. What's interesting about this is this is why bodybuilders love testosterone, is if you give testosterone to a man, that increase in weight will be muscle mass, and actually their fat mass will be reduced. So you can decide whether that's a side effect or a side benefit. I suppose it depends on whether you're a jockey or a bodybuilder. But this does happen with testosterone. There is a slight increase in oiliness of the skin and acne. Again, the same things that happens when boys go through puberty. There is about a 10% decrease in the serum HDL cholesterol. Now, this is the good form of cholesterol, so we're not sure about whether or not that's a good thing, but it is something that's noted in most studies. And most importantly, and this is the question that always gets asked, is these men really don't experience significant changes in libido, aggression, prostate, or cardiovascular health. So we do think that this is fairly safe. Obviously, if you were to introduce something like this, you would need to follow the men who were taking it for a fairly long period of time before you really fully understood the long-term consequences. But certainly in the short-term studies that have been about a year to date, we don't see any major adverse effects that would make us think that this is something that would be dangerous for men. Again, because these are hormones that their bodies are normally exposed to. One thing that is notable is because you are suppressing the levels of FSH and LH in these men via the negative feedback at the level of the hypothalamus and pituitary, you decrease FSH and LH. The testicular volume, as a result, shrinks by about 20 to 25%. What's interesting about this is men don't notice it. If it shrunk the size of their penis, they would notice it. But it doesn't. Fortunately, that's not the case. It shrinks the size of the volume of the testis, which we can measure in the clinical studies. When the man stops the hormones, the FSH and LH go up again, and the testicular volume returns to baseline. Basically, what we say to men is, the testes are smaller because there's no sperm there, which I think is a fair approximation. So just to summarize the first part of this talk, testosterone alone is a male contraceptive. Well, it can result in rates of azoospermia between 60 and 90%. And something I didn't get into is this actually varies via ethnic groups for reasons that are not clear. We can talk about that in the question and answer if people are interested. Overall, in the studies that have been done, the contraceptive efficacy, if you include the people who respond and the people who don't and lump them all together, about 95% of men would have effective contraception from this approach to contraception. There is this delay in onset that I measured, and the short-term side effects seem to be fairly mild and well tolerated by subjects, although you'll hear directly from our subjects as to whether or not that's the case a little later. And the long-term side effects / benefits are not entirely known. And this is an interesting area. You know, the female contraceptive gets a lot of press, both pro and con, but I think one of the things people don't emphasize enough is that the female contraceptive is actually associated with a reduced risk of both ovarian and endometrial cancer and has other non-contraceptive benefits. It's quite possible that this sort of hormonal manipulation may have beneficial effects for men, and similar beneficial effects for men, and wouldn't that be great? It just needs to be studied down the road. Some people ask me when they hear this data, they say, gee, that testosterone injection you showed me looks pretty good. Why isn't that available on the market? I think that's a fair question. At the time that the study was done, the drug companies who would be involved in the development of this thought that the requirement for weekly intramuscular injections, which is how the testosterone was administered in these studies, would not be appealing to men. So it was kept off the market. And so what I'm going to talk about in the next few slides is efforts to improve on this by making testosterone preparations that last longer and would be less onerous for subjects. I want to just show you some data first, though, from these kind of studies. What you're looking at here is, on the y-axis, is the sperm concentration in millions of sperm per milliliter of ejaculate. Remember that I told you that the normal range is 20 to 200 million. And what you're looking at here is there's 3 phases to these studies. There's this baseline phase over to the left side of the figure. And then you can see in the middle is a treatment phase. This is 6 months in duration where men are receiving injections. And then there's a recovery phase. And in this study, we were comparing testosterone alone to testosterone plus a progestogen called levonorgestrel that many of the women may recognize as a component of the female birth control pill. And you can see that on the left side of the figure, the individuals start out with a mean sperm count somewhere in the 40 to 80 million range. And you see that moves around a lot, and that's pretty common actually with sperm production. Then at the left side of this treatment box, you can see the individuals are starting testosterone or testosterone and levonorgestrel treatment. And you can see pretty rapidly, especially in the combination group, by 2 to 3 months, the mean sperm count is fairly close to 0. And you can see that there's significant synergy here, that the combination of testosterone and levonorgestrel in the black is significantly more suppressive of the sperm concentrations than the testosterone alone. Then again, at 6 months, the treatment ceases, and you can see after about a 2 or 3 month treatment period, the sperm counts return to where they started, to baseline. And this is the kind of graph that you'll see in these studies, and so people are trying different hormones and different combinations. But the basic principle is the negative feedback regulation at the level of the brain of the signals FSH and LH that are required for sperm production. This is a Chinese study using a much longer acting. I mentioned that the testosterone injections in the earlier study were given weekly. What you're looking at here is a very similar paradigm with sperm count on the y-axis and time on the x-axis. Do you see these 3 little arrows there? Those are when the injections were given. So they have a formulation of testosterone that's ultra long acting called testosterone undecanoate, and it can actually be given every 8 weeks. This is getting close to the injection frequency of Depo-Provera, which is a commercially available female contraceptive, which is every 12 weeks. In this study, men were randomly assigned to testosterone undecanoate alone every 8 weeks, or the combination of testosterone undecanoate and DMPA, which is another one of these progestogens. And you see something very similar. You see that the testosterone is suppressive during the treatment period, but the combination of testosterone and the progestogen in this trial, given every 8 weeks, was very suppressive in this group of men from China. So every 8 weeks injections are good, but a lot of men don't like going to the doctor every 8 weeks. Certainly the men I see in clinic don't. So we've also thought about other alternatives to developing delivery of steroids. And implants are actually a very good one. Are most of you familiar with Norplant, which has been subsumed by Implanon? These were attempts to develop long-acting reversible methods of contraception for women. Implants turn out to be a very good long-term delivery system. They can be implanted in a minor surgical procedure, and then they can secrete the hormones at a very steady state level, so there's none of the peak and trough effects, which we think are associated with negative symptoms. You can put the hormone in these silastic capsules and implant them, and they give a very steady state levels. The one drawback, of course, is that it does require a minor office procedure to place these in the arm, but they can last for up to a year. So that would be one alternative for men. This is just getting back to the earlier point that I made about would men use a contraceptive. I think if you look at it, probably the majority would. I think this is the kind of thing that would need to be introduced and would potentially gain interest over time. One thing that, if you ask men and you say to them, what would you prefer as a form of a modality of administration of the testosterone, they would like an oral pill, very analogous to what women would like. That has pros in terms of its appeal to men. It has drawbacks in terms of men actually doing it and remembering to take their pill every day. That's what women ask me. They say, would the men really remember to take the pill? And we can talk about that later. Certainly, the longer the injection interval, I think the more appealing it would be to men. And weekly injection, you can see on the bottom there, was not particularly appealing to men. When you ask the men after the fact, what did you think of this method of contraception? Most of them actually think it was as or better than expected, which is good news to hear. Men don't profess to any change in the quality of life. And importantly, the sexual frequency, sexual enjoyment, all the sexual parameters that we query study subjects about don't seem to change significantly. So this is just the obligate New Yorker cartoon. You can't actually go to the fair and guess your sperm count, but if you're really interested, you can come by the lab. So what can you say about male hormones? Well, in most settings, you can see reversible inhibition and spermatogenesis in most, but not all men. And why some men don't suppress, we don't know. Dr. Anawalt's going to talk briefly about our efforts to try and understand that in a few moments. We think of them very safe. They seem to have minimal short-term side effects. They seem to be acceptable, at least in questionnaires and certainly to study subjects. One of the things we're really actively working on now is trying to engage the pharmaceutical industry in getting back into interest in this field, because really, if you're trying to bring something to market, you need to have a partner within the pharmaceutical industry. And this is just one of my favorite quotes. Albert Einstein's a sort of a hero of mine, very smart man, and I think he was right on about this. So thank you.